Good evening, everyone. My name's Louise Hager, and as Chairman of High Cancer Care, it's my pleasure and privilege to welcome you to this year's Natalie Shipman Memorial Lecture. Also gives me great pleasure to welcome Professor Jonathan Lederman, who is our keynote speaker, and also Dr. Adrian Tuchman, who is Chairman of our Medical Advisory Panel. If you would like any feedback on tonight or you'd like a CPD, please do email Danny where you got the link from, just reply to her. I just want to give you a little update of what's been happening at Chai in the past year. Well, thank God we are back and fully operational in all our centers, which has given us tremendous pleasure, not just us, of course, all our clients. The buzz, the welcome has been tremendous. But we've also managed to learn from COVID. Of course, all of us have experienced the things that weren't so wonderful. We see that every day here at Chai. But as an organization, we really have grown from it. And now we are doing much more hybrid. So many of our groups, traditionally, people had to come to a center, but now they can join in a group from all over the UK and indeed abroad, which has really brought tremendous comfort to many, many people. We continue to see the impact of COVID, as I said just before. And in fact, in the last year, we have had just over 950 new clients need to turn to Chai. And I just want to pay tribute at this stage to the most incredible team at Chai. Each and every person goes above and beyond to make sure that we can do whatever we can do as quickly as we possibly can to help people go through living with the impact of a cancer diagnosis. And for that, as I said, I pay tremendous tribute to everyone here at Chai. Of course, there are pressures, and you will understand as my position as chairman and making sure that Chai can carry on. We are this year going to be having another matched funding campaign on the 27th and 28th of November. This will all be part of a Chai Shabbat, a Chai awareness weekend, where we will literally be touching as many areas of the community as possible, making them aware of the different services that Chai provides and the immense and tremendous impact we have on people's lives. In fact, the campaign is going to be called The Big Impact. Again, drawing a notice to Chai's Big C of Care. And if anybody is interested in helping us in any way, please, please do contact us, because we're all part of this one big community, the wonderful UK community, and indeed abroad to support Chai. And if we can all join together and make sure that we can do whatever we can to ensure that Chai can continue to provide our Big C of Care, heartfelt thanks from us all. As tonight is, of course, this lecture is dedicated to our precious Natalie Shipman, who I don't even have to close my eyes to see her. It's over 30 years, and it's as if she was just standing here. Her personality in that little bundle, she wasn't even 8 years old when she sadly passed away. Yet, and however ill she became, I can't explain to you the soul in that little girl, her warmth, her positivity as she faced the most tremendous challenges in her short life, having been diagnosed just when she was 3. And everybody who had the privilege to know her, it really was a privilege. And I want to pay tribute, of course, to dear Susan, Natalie's precious mother, who was driven that something positive must come of Natalie's short life. And together with my mother, Frances Weingarten of blessed memory, they created this incredible organization that we all feel so passionate about. Why is that? Because every single day we do see the impact, and forgive me for saying it again, but it is true and we can't avoid the truth. We do see that impact, and that impact will always be remembered as coming from Natalie. And we pay tribute to Natalie and to Susan for having the drive, the passion, and the commitment to making sure that other people shouldn't have to go through a cancer diagnosis without support. And bless you, Susan, and please God, you should be well for many, many more years. And thank you for everything that you did for Chai and continue to do, even from afar. I now want to pass over to Dr. Adrian Tuchman, who is chairman of our medical advisory panel and a trustee. Adrian is the most incredible, devoted person. I know he's not going to like this, but Adrian, we really are so grateful for all your continued input, advice, guidance for so many years, and please God, for many, many more years. And over to you, Adrian.
Thank you, Louise. Thank you very much for that. The joy and pleasure is working for an organisation like CHI. It continues to offer support to people and families who have cancer in the family. And one of the great advantages and one of the things that makes CHI a very important organisation and is that they acknowledge the importance of having expert medical oversight. And it's been a privilege and a pleasure to chair the medical advisory panel and be a trustee. And it's wonderful to work with leaders in the field. So I'm going to be brief. As I said, thank you, CHI. I'm speaking on behalf of everyone who's been involved with you. And I'd like to say that we are so fortunate to have leaders in the field of cancer who can deliver the Natalie Shipman lectures. Last year, we had Professor Danny Hockhauser talking about individualized cancer treatment, hype or reality, which was an amazing lecture. This year, we are very privileged and fortunate enough to have Jonathan. And Jonathan, I've known Jonathan for many years. We've been close colleagues. He's been involved with CHI since the very early years and is a very valued member of the medical advisory panel. A brief curriculum vitae, CV. Professor of Medical Oncology in the UCL Cancer Institute and Director of Cancer Research UK and UCL Cancer Trial Centre. He has worked at UCH, University College Hospital, since 1990. Specialises in gynecological cancer treatment and research. He's had many leadership positions in national and international research organisations, including an organisation called the NIHR, the National Institute of Health Research, where he's been a senior investigator for, excuse me, and the fellow for the Academy of Medical Sciences. He's vice president of the European Society of Gynecological Oncology, deputy editor for ESMO Gynecological Cancer. He's been chair of the Gynecology ICG Rare Tumour Group Working Party on the Council for many organisations. We are therefore privileged to have Jonathan talk to us about something that is incredibly important to the Jewish family. So, Jonathan, over to you. Thank you. Any comments, please put them in the chat. And at the end, we've got 10 minutes at the end to try and answer all questions that are being put into the chat, the comments. So, Jonathan, over to you. Nice to see you this evening.
Thank you, Adrian, and thank you, Louise. It's really an honor to be invited to give this year's Natalie Shipman lecture. I've been involved with CHI, as Adrian has said, for many, many years and seen the organization grow in strength, size, and influence, and it's really been wonderful to be associated with it. Let me now just start my presentation. So I'm going to talk this evening about how our understanding of BRCA mutations has increased our knowledge of the biology of ovarian cancer and also how it has led to significant improvements in the treatment of ovarian cancer. Let me start by saying something about BRCA genes and the risk of cancer. The two most important cancers associated with BRCA-related risk are breast and ovarian cancers. And you can see here the lifetime risk for breast cancer and ovarian cancer. But in the presence of a BRCA mutations, and there are two BRCA genes, BRCA1 and BRCA2, you can see that the incidence or risk of breast cancer increases hugely, principally in women, but also to a degree in men. And the risk of ovarian cancer increases substantially. Other cancers such as pancreas and prostate are also more commonly associated with BRCA mutations, but I'm going to focus this evening on ovarian cancer. Now, the BRCA genes, BRCA1 and BRCA2 genes, encode enzymes that are important in the repair of strand breaks of DNA, and I will come on to that in more detail in a moment, but that is their principal function. Screening is not really a topic that I'm going to go into any detail this evening. It's really a big subject and worthy of a separate talk, other than to say that BRCA mutations are present in about 1 in 400 of the population. But among the Ashkenazi population, they're found much more commonly. About 1 in 40 people, about 2%, have a BRCA mutation. And screening for BRCA mutations has historically been performed on the basis of family history of breast and ovarian cancer. But there are now discussions taking place for routine screening, and the whole field has been really thrown into the foreground by publicity, particularly as you see on the right from Angelina Jolie, who has a BRCA mutation, and very publicly discussed the risk-reducing surgery that she had, which is needed in order to prevent tumors from developing. General population of screening of ovarian cancer does not at the moment reduce deaths, but breast screening does. And the only real way of preventing ovarian cancer in patients with a BRCA mutation is by removal of the ovary. So what have BRCA genes taught us about the biology of ovarian cancer? Well, we know that ovarian cancer is not one disease. And when we look under the microscope, there are different types of ovarian cancer. But the most common is high-grade serous ovarian cancer. And this is determined by looking at it under the microscope. But when we look at the disease, we can see this very similar disease affecting the ovaries, can also affect the fallopian tubes that are connected to the ovaries. But you can also see tumor involving the peritoneum, the peritoneal lining, without actually involving the ovaries. So this was always a curious finding, that you see exactly the same tumor in any of these three sites, and we couldn't really explain why it was or how they got to these different sites. That was until work started to remove the ovaries and the fallopian tubes of women carrying a BRCA mutation. So this was the way of reducing the development of ovarian cancer, by removing the ovaries and fallopian tubes. And when the fallopian tubes were looked at in detail in some of these women, there were present something called stick lesions, which is serous tubal intraepithelial carcinoma. But a stick lesion seems to be a pre-malignant lesion that is found in the fallopian tubes, and there was no evidence of cancer in the ovaries. So putting this together with a lot of other research, it's now clear that actually the most common type of ovarian cancer, serous ovarian cancer, doesn't actually originate from the ovary. It originates from the ends of the fallopian tube, and you can see that schematically, this fimbrial frond-like ends of the fallopian tube where these initial pre-malignant lesions occur. And then bits of those tubes or cells from those tubes fall off, get incorporated into the ovary, then develop into a tumor, which we call ovarian cancer. Or they may stay in the fallopian tube, and we call it fallopian tube cancer. Or the cells may float off and lodge somewhere in the abdominal cavity on the peritoneum and produce a condition called primary peritoneal cancer. So what study of the BRCA patients has told us, or women, I should say, with a BRCA mutation has told us, that there is now this stepwise development of ovarian cancer that originates in the fallopian tube. So how do BRCA genes then help us to develop new therapies for ovarian cancer. Well, to understand this, we need to understand a little bit about the function of the BRCA proteins and to understand a little bit about the repair of our DNA. So as we sit here this evening, our DNA is sustaining breaks, fractures, if you like, in the strands, the double strands shown here with this arrow. And these have to be repaired so that the cell integrity is maintained. And one of the first steps that happens is an enzyme called PARP, poly-ADP-ribose polymerase, attaches to that broken strand of DNA and brings in a whole load of proteins to help repair that break. And this is a process called base excision repair. Well, if you block that with a PARP inhibitor, a drug that inhibits PARP, then that process can't take place. And we knew for some while that BRCA proteins were involved in this repair process. And the first studies, which were done in cell lines, cells that were deficient in the BRCA gene, and therefore the BRCA protein, in the presence of these PARP inhibitors, it was shown that these cells were very sensitive to this PARP inhibition, 1,000-fold more sensitive than if the cell had a normal functioning BRCA protein. And it was this really that led to the idea of using PARP inhibitors in BRCA mutated tumors to see whether or not they could be therapeutic. Because here you can see, and I just show this schematically, that the BRCA proteins are very much involved in this process of repair with a lot of other proteins that I just showed you earlier. And that if you have this gray deficiency on the right-hand side, this leads to incomplete repair and indeed cell proliferation of faulty DNA, which in itself can generate tumors. So here is a little cartoon to show this in action, if you like, with this single strand break of DNA. PARP comes along to repair, the inhibitor is given, and what then happens is that this is bound up in the complex, and when the cell tries to divide, the DNA splits, and you have this double strand break of DNA. Now, in a normal cell, this is repaired by a process called homologous recombination repair that brings together the two ends of DNA. But in cells that are deficient in homologous recombination repair, which we sometimes abbreviate to HRD, HR deficiency, such as a cell which has a BRCA mutation, then that leads to cell death. And so by using a PARP inhibitor, you produce tumor-specific killing of these cells that have this inability to repair. Just to put it finally in another way, if you think of a table that has these four legs and base excision repair is managed through PARP, and if you block that, you lose one of the legs, but the table is still standing because the homologous repair process is functioning. But in a cell like a BRCA deficient cell, where the homologous repair process is not working, and you then interfere with the other leg, the table falls down. So that is how PARP inhibitors work. And that was tested about 12 or 14 years ago in the clinic with the first PARP inhibitor drug called olaparib in tumors that were carrying a BRCA mutation. And quite surprisingly, in these patients who'd been treated with all sorts of different drugs for their cancers, mainly breast and ovarian, but there were other cancers too, there was a high proportion of patients who not only responded, over a quarter of these patients actually had tumor response, and that lasted for up to 7 months. And that was then expanded in a group of women with ovarian cancer. And you can see here, a third of these patients actually had tumor shrinkage, and that lasted on average 9 months. Just emphasizing that these are women who have had multiple treatments which failed to work or ceased working, and then responded to olaparib. And this was published in 2009. And here I just showing you from that publication two CT scans showing you an example of this reduction in tumor. On the top, you can see ringed a tumor just below the navel in the front of the abdomen, and then becomes smaller within a few months. And on the bottom two pictures on the left and the right, you can see the tumor ringed disappears within 3 months. So the question then arose as to how best to introduce these PARP inhibitors into the clinic. And at that time, I was interested in developing new drugs and evaluating new drugs by looking at whether or not they could alter the natural process of tumor response and progression that we saw in women who had recurrence of ovarian cancer. So the schema here on the top is what typically happens if a patient has a recurrence of her ovarian cancer. She's treated with chemotherapy and responds, and then we stop the treatment and we watch and we wait for a period of time, which varies. And at some point, unfortunately, the tumor starts to regrow, and then we consider using another chemotherapy. So the question is whether, if at the end of chemotherapy you add in a biological agent such as a PARP inhibitor, whether you can usefully extend the time that the disease is controlled before you have to restart chemotherapy. And this is what we started to do in 2008 with PARP inhibitors, with olaparib, to test this out in the clinic. So put simply, we took women with recurrent ovarian cancer who had responded to chemotherapy, finished their chemotherapy after a recurrence, and then at the end of that, gave them either olaparib as maintenance or placebo, because the standard was just monitoring observation. And then we looked to see how long it took until the disease came back. Now, this was the result, and I'm just going to spend a moment explaining this to you because there are one or two of these survival curves, and if you're not familiar with them, it gets a little bit complicated. So what this curve shows is the proportion of patients who are free of disease progression. So when we start, 100% or 1.0, the proportion are free of progression. But with time, which you can follow at the bottom, some of these patients will suffer a recurrence. And that curve is showing you the fall off of patients who then get recurrences at certain times. And what the two different colors show you are the gray color is the placebo and the maroon color is olaparib. And you can see this big difference of giving maintenance olaparib over placebo. You are delaying the progression of the disease in these women. So homologous recombination deficiency, I mentioned, is really the hallmark of whether or not a tumor will respond to a PARP inhibitor. And that can be seen in patients with a BRCA mutation, but it also can be seen in quite a few patients with ovarian cancer who do not have a BRCA mutation. And schematically, you can think of it like the moon here, with a light side and a dark side. And about a quarter of all patients will have a BRCA mutation, either in BRCA1 or BRCA2, inherited mutation. But you can also see mutations that are acquired, so not passed on from generation to generation, but are present in the tumor if you look in the tumor. Or you can see the gene present, but it's silenced, it doesn't work. And that accounts for about 25% of all women with high-grade serous ovarian cancer. But there are another 25% that don't have BRCA-related causes of HRD, but nevertheless have this homologous recombination deficiency. So about 50% of patients with high-grade serous ovarian cancer can benefit from PARP inhibitors. But of course, there is a dark side to the moon, a group of women, a group of tumors that don't respond to these drugs, and we need to understand why and develop other drugs for them. When we go back to that study that I showed you, we looked in more detail at the patients with a BRCA mutation and those without a BRCA mutation. And olaparib was effective in both, but it was more effective in patients with a BRCA mutation on the left than it was without a BRCA mutation on the right. But there was still a clinically significant benefit in both groups of patients. And this led to actually a series of other studies and publications with different PARP inhibitors as well as olaparib. And as a result of this, over the next few years, we actually had 3 PARP inhibitors, olaparib, niraparib, and rucaparib, that all became licensed as maintenance therapy in any patient with recurrent high-grade ovarian cancer after response to platinum therapy, irrespective of whether they had a BRCA mutation. So that was really the first big step of bringing PARP inhibitors into the clinic and making a difference to these women with recurrent ovarian cancer. PARP inhibitors actually are very similar in terms of their side effects, and these are tablets, and in the main, very well tolerated. You can see here for olaparib, the most common types of side effects: nausea, fatigue, and anemia. But some of these side effects, or most of these side effects, I should say, are really quite mild, and you see in the darker colors the ones who have more serious side effects. But most patients tolerate the treatment very well for often a prolonged period of time. And you can see this shown schematically from one of the trials that we did with olaparib, where we look in the different colors here over the months of treatment here, over 24 months of treatment, at the dose of drug that women were taking. Because if we have to reduce the dose, it means they're not tolerating it very well. And what we found was that 25% of patients do need to have interruptions in treatment, or drug holidays, as we sometimes call it. 25% did need to have a reduction in the dose, but only 11% of all the women in the trials actually discontinued treatment because they felt the side effects were too unpleasant. So for most women, they can continue the drug, as I said, for many months and actually sometimes years. In this example, in women with a BRCA mutation receiving olaparib, you can see the length or the percentage of patients who are on treatment for 3, 4, and 5 or more years. And in fact, in this trial, over 20% of the women continue to receive olaparib for more than 5 years without any evidence of tumor regrowth, and we're able to tolerate that drug for that period. And we have patients who are on the drug beyond that, but as you can see, many of those patients don't get to that period of time. It's a small but significant number who really have this exceptional benefit from this type of drug. So let us turn now to first-line treatment of ovarian cancer, because having shown that there was a benefit of PARP inhibitors in women with recurrent disease, the next question was, could we actually reduce the number of women who actually get a recurrence of their ovarian cancer? If we look at the statistics, and these are now relatively, well, old statistics, I should say, after what I'm going to show you in the next few minutes, but around about 7,500 women in the UK are diagnosed with ovarian cancer each year. Most of those will have advanced disease that's spread beyond the ovaries, and 70% of those women generally would have a relapse, a recurrence, within the first 3 years of treatment. And the expected 5-year survival is around about 30 to 50%. So those are the historical data that we have. And the question is whether or not, if we bring PARP inhibitors in that frontline treatment, can we change that statistic, those figures? So this is shown a bit schematically here, in that a woman with a newly diagnosed ovarian cancer will undergo surgery to remove much of the tumor, as much as possible, and that will be followed by a course of chemotherapy. And at the end of that, we will often say, we can't see the cancer, we can't see it on a scan, we can't see it on any of the blood tests. But we know, as I showed you in the previous slide, that a high proportion of those women will have a recurrence. So there must be disease that still remains that we can't see, that grows with time. So the question is whether, if we use the PARP inhibitor as maintenance, as we did in recurrent ovarian cancer, can we prevent or delay that recurrence from occurring? So that was tested in a trial that was called the SOLO-1 trial, designed in a very similar way to the one I showed you in recurrent disease. It took women with newly diagnosed ovarian cancer who all had a BRCA mutation, and at the end of surgery and chemotherapy, they were allocated either olaparib or placebo, because again, standard of care is observation and to see what happens. And that was given for up to 2 years, unless the patient suffered a progression of disease during that time. And the primary analysis was to look at the progression-free survival, the time of the disease remained free of progression, as I showed you earlier. But of course, other important measurements were the overall survival of these women. So we come back to the type of graph I was showing you earlier on, and you can see here quite clearly this big difference in the women that received olaparib compared to the ones who received the placebo. So the treatment was stopped at 2 years, which is the green line, and you can see that after that period of time, there were a few, but only a few progressions. The curves remain parallel, and at 3 years, 60% of these women are free of progression, opposed to 27% of the women who were on placebo. So this was a very big difference. And of course, it led immediately to the incorporation of olaparib in frontline maintenance therapy of women with BRCA mutated ovarian cancer, because we had not seen these big differences or differences as big as these occurring previously. Very recently, 6 weeks ago, we saw the 7-year survival results from this trial. And this shows, as you can again see from looking at these curves, that they remain well separated. And at 7 years, 67% of these women who were diagnosed with advanced ovarian cancer remain alive, compared to just about half the patients, just under half the patients who had the placebo. Now, of course, many of those patients who had placebo then received a PARP inhibitor at the time of a recurrence. 44% of them, in fact, crossed over. So the curves do come together a little, but nevertheless, what it does show is that there is a difference in the survival if you give the drug at the beginning, at first line, which is what was done here. The other thing to note is there's very little difference in the survival at 5 years to 7 years. The curves look as if they're flattening off. And that to us is very encouraging, because it does suggest that cure may be possible in this group of women. Another way of looking at it, and I'm not going to show you too many more of these graphs, but they just are, I think, very powerful in the messages that they give. This is looking at the time from the start of treatment to the next line of treatment, so that if a woman does have a recurrence, she will have more chemotherapy. And so with time, some patients are suffering a recurrence and having more chemotherapy. And you can see the two lines, the orange olaparib line and the blue placebo line. And the point to focus on is, again, the 7-year time point, because 45% of this population of women on olaparib have not had a second line of treatment. So that adds weight to the belief that actually many of these women are going to be cured by using the olaparib. But we will have to wait longer to see what happens to these curves. It is a 7-year point, but the trial needs to wait to be more mature to know whether these parallel curves, if you like, continue. So I've spoken about tumors, BRCA mutated tumors, which can either be inherited germline or non-inherited somatic, which comprise around about 25%, as you saw on that moon picture of the tumors. But as I said earlier, about another 25% of tumors have this homologous recombination deficiency, making up that 50%. So the question is, will those patients also benefit from PARP inhibitors in the front line? And that was looked at in 2 clinical trials, which are called the PAOLA-1 and the PRIMA trial. One was with olaparib, which was actually given together with bevacizumab, which is an antibody that targets the blood vessels that tumors need to grow. And the other trial was with another PARP inhibitor called niraparib, which had been used in recurrent ovarian cancer, as I showed you earlier. And the questions being asked in this study was, will these drugs work beyond BRCA? That is to say, in those patients who are what we call BRCA wild type, who do not have a mutation. And will it work in tumors that have homologous recombination deficiency, or will it work in all tumors, even those that don't have homologous recombination deficiency? Well, how do we test for all that? The first thing is to look in the tumor and see whether there is a BRCA mutation. That means disruption of both BRCA genes. So we carry pairs of genes on our chromosomes, and in a BRCA mutated tumor, both the genes have been damaged, as you can see schematically. So looking at the microscope, down the microscope, if you like, or it's actually testing the tumor, you can see whether or not there is a BRCA mutation, but you don't know whether it's inherited or whether it's just arisen in the tumor. So to do that, you need to test the blood and look at circulating white blood cells or other cells where you can extract the DNA and see whether or not in all the cells there's loss of one BRCA gene, which is what happens when you inherit a BRCA mutation. And that will say whether or not the tumor has a germline mutation or a somatic mutation. But that doesn't tell you whether HRD is present. We know that HRD, this homologous recombination deficiency, is present in BRCA mutated tumors. But as I said, about another 25% have HRD without a BRCA mutation. So there are a number of tests that are being developed to measure this homologous recombination deficiency within the tumor. And this is sometimes called the genomic instability test. And without going into too much of the detail, the most commonly used one is the myriad test, which looks at the degree of genomic scarring that occurs in cells that are homologous recombination deficiency. And you can measure that degree of scarring and give a score out of 100. And any tumor that has a score above 42 is termed HR deficient, and a score of less than 42 is an HRD negative tumor, doesn't have that genomic instability. And that was used in these trials. And here you can see, just very much like the schematic I showed you earlier on in the PAOLA-1 trial, actually 29% of patients in this trial had a mutation of BRCA, either inherited or somatic, and about 20% had non-BRCA, but 48% were HRD positive. So just to summarize, without going through more and more curves, when olaparib was added here to bevacizumab, there was, at 5 years, a 10% improvement in the overall survival. And again, those were data that were presented just 6 weeks ago. So it's really very, very new data. So the overall survival is improved by around about 10% by adding olaparib to bevacizumab in these patients without a BRCA mutation. In women who do not have a positive HRD test, there was really only a minor clinical benefit from a PARP inhibitor. And I think we question what the value is of adding a PARP inhibitor if the HRD test is negative. But testing now for HR deficiency, HRD, in the tumor is becoming routine. It's funded throughout the NHS. So all women with newly diagnosed ovarian cancer are offered not only BRCA testing for germline and tumor, but they're also offered HRD testing in the tumor so that we can identify whether they have a biomarker in their tumor that is likely to lead to a beneficial outcome when we use a PARP inhibitor. So BRCA mutations have really opened up a completely new area of ovarian cancer treatment. They've taught us a lot about the biology of ovarian cancer. They've taught us, or are teaching us, a lot about how important it is to target DNA repair, how crucial that is in terms of getting on top of tumor growth. And it's triggered a whole host of new research looking at, if you like, second generation type drugs that will work to interfere with this DNA repair process. But the initial work in the recurrent ovarian cancer setting has shown that that these PARP inhibitors will significantly delay regrowth of cancer and give women a lot longer time free of disease and free of symptoms. And it's shown that we can use PARP inhibitors beyond tumors that are BRCA mutated, because there are these other tumors without BRCA mutations that have this inability to repair DNA and therefore sensitivity to PARP inhibitors. Most recently, in the frontline treatment, the first-line treatment of ovarian cancer, we've seen the benefit of olaparib, as I showed you, improving survival, 7-year survival of 67%. And that's extending the survival in the more traditional way by over 20%. And that includes women who went on to access PARP inhibitors later on. So still that difference of 20% remains. 45% of those women treated those women with a BRCA mutation who were treated with olaparib have not had a single recurrence at 7 years. And in the first line setting, again, in this HRD positive tumor setting, if you test the tumor and there's no BRCA mutation, there is clinical benefit of adding a PARP inhibitor. But PARP inhibitors do not work in all women. Even some of those with BRCA mutations are resistant to PARP inhibitors, and much more research is needed to understand why this is occurring and to try and overcome this problem. And in those women who have a benefit from PARP inhibitor that is short-lived, we need to understand what it is, what's happening in the cancer cells, so that they, as they're adapting and becoming more resistant to treatment. Just want to finish with this slide, which is taken from given to me by a colleague of mine from the US, which is looking at the incidence of ovarian cancer and the mortality, the death from ovarian cancer over a 20-year period. And these are taken from a large statistical repository called the SEER database in the USA. And what you can see over that 20-year period is that there has been a fall in the incidence and mortality of ovarian cancer to a degree. But what I want to show you now is the prevalence of the disease. That's the number of women who are alive with a diagnosis of ovarian cancer. And what you can see is that that has increased over 20 years as we've got better in treating and controlling the disease. And then in around about 2014 and 15, there was this very sharp uptick of women having ovarian cancer and living with ovarian cancer, to the extent now that the prevalence is much higher than the incidence, which means we've got a lot more women alive with a diagnosis of ovarian cancer than we had before. And that sharp uptick coincides with the introduction of PARP inhibitors in the clinic, the general licensing of PARP inhibitors in the USA and in Europe. So I think it really has made a difference to the disease management, as you can see here. So I will just finish by really summarizing that the study of BRCA mutations has opened the door to new cancer treatments and continues to do so, as it's taught us so much more also about the biology of the disease. And I would just like to acknowledge the great contribution of colleagues from the UK and from around the world, the research funders and the pharmaceutical industry, and of course, the patients who were involved in this research. Thank you for listening, and I'm very happy to answer any questions.
That was fantastic, Jonathan. Thank you so much for that insight. In interesting times, I think we have to say. Can I suggest that if there's anyone who wants to ask a question, that the comment box is now open. So if you write in the comment box, we'll try and get Jonathan to respond to that. A question from me, Jonathan. the world of cancer is changing, isn't it? I mean, it's now for many being turned into a sort of a chronic illness. How is that going to impact on us in the medical world and people in general? What sort of support do you think needs to be offered in that sort of chronic look? If you understand where I'm coming from, yeah.
Yeah, no, I do. So I think there are two main aspects to consider here. The first is a chronic disease where the disease is still there, but it's managed, and of course that requires medical nursing intervention. Patients, for example, on PARP inhibitors and maybe on PARP inhibitors for a very long time, and we need to adapt our clinics and care pathways so that we can look after these women and manage the disease. And then there's the other aspect of it is of course the psychological and social aspect of being alive with a disease, how it affects one's work, one's family, and one's attitude to life. In former times when sadly patients often died quite quickly after a diagnosis of cancer, that was an extremely traumatic process for patients, for families, but it was over in a relatively short period.
Yep.
Now, living perhaps for many years with cancer, it brings different issues up which need to be helped with, supported. So I think there is a change that we will need to adapt to because of this.
Yeah, no, we are certainly going to need to develop support services. I mean, that's one of the reasons that organisations like HI exist, and HI is really leading in this area. I need to actually say this is being recorded. There's a question here about that. So in those who can't join in, there'll be a recorded version of this. I have a question here. Thank you for this fascinating talk. Can you offer any insights as to the benefit of PARP inhibitors for BRCA carriers affected by other cancers, pancreatic, breast, prostate?
Well, so I think the two elements of this question in terms of carriers or patients with disease, and I suspect that the questioner is really referring to disease. So PARP inhibitors are active in breast cancer, and it's recently been licensed in certain types of breast cancer. They're also active in prostate cancer, and again, they're available in certain situations in prostate cancer where it's due to BRCA mutations, and also some benefit in pancreatic cancers, which rarely but do occasionally have BRCA mutations. So that's the therapeutic side. I'm not quite sure whether the question was also asking about carriers. I'll address that now because it's often a question that does come up as to whether or not, if a patient is a carrier, there's any use for a PARP inhibitor. I think the concern there is, and I didn't really spend a huge amount of time in terms of toxicity, mentioning just the sort of more acute toxicity, but there are some concerns about long-term use, very long-term use, in that it can actually in itself predispose to particularly blood malignancies, and therefore one would be very cautious about recommending the use of a PARP inhibitor in a healthy individual who happens to carry a BRCA mutation.
Yeah, because there is an issue here, isn't there? I mean, there's been a governmental push about genomics in medicine, hasn't there? So I guess one of the questions that people may be thinking of is, should families be tested if there's a BRCA gene in an ovarian, prostate cancer?
Well, the simple answer is yes. So what happens is that we offer BRCA testing to all newly diagnosed patients with ovarian cancer. If it turns out that they have a germline BRCA mutation, then we will refer the patient to a cancer genetics clinic where there'll be a discussion about family members, contacting family members, discussing the situation with family members, and offering the family members testing. So if that really takes off, then that's likely to reduce the incidence of ovarian cancer and indeed breast cancer too over the years, which will be a good thing. Of course, it does involve an operation removing the ovaries and the tubes, and of course the timing of that is important, particularly in relation to lifestyle and childbearing. But there is a way then of preventing ovarian cancer in these women. I think the wider question that is actually now being discussed, and I didn't really want to get into it tonight because
I
it's a
understand
topic
that
on its own, but it's just worth mentioning, is that there is now discussion about population testing for ovarian cancer. This is not, sorry, population testing for BRCA mutations. Yep. This is something that is now being thought to be potentially feasible as the cost of testing comes down and therefore more cost effective. So we may see that in the next few years. It started in Israel. So in Israel, there is now population testing for BRCA mutations. And of course, that will have the effect of, again, reducing the incidence of ovarian cancer and breast cancer.
Yeah, and obviously there's a lot of monitoring and oversight of what is going on in places like Israel, isn't there? We need to learn from that. We need to learn from that. It's probably important to say is that CHAI does offer BRCA support. There's BRCA support group for individuals who and families with BRCA genes. There's a women's only group. There's also a mixed group as well, but I need to add that to the conversation. Now I have a question here. Thank you for this very interesting discussion. I'm currently on olaparib after being offered it after first-line treatment. I didn't have a recurrence. Are there any statistics about dosage versus recurrence? Thanks.
Yeah. So that's an important question, because a lot of our patients, when we go through the problems with managing the toxicity, and I say to them, if we really are struggling, we're going to take the dose down. And a lot of women will say, oh, no, I'm prepared to struggle with my fatigue or my nausea. I don't want to take the dose down. Actually, we don't know that slice, well, I should put it in a slightly more positive way. There's no evidence that slight reduction in dose has any detrimental effect. So when we give a dose of the drug, we're just giving a flat dose, 300 milligrams. It takes no note of the patient's height, weight, metabolism. So different patients are going to metabolize drugs differently. And what's good for someone of a certain person for 300 may be just as good as someone taking 250 or 200 milligrams. So if we really can't manage the side effects, we would recommend to take the dose down, and there's no evidence that is going to be detrimental to that individual.
Thank you.
I hope that answers her question.
Thank you. So let me just ask if there's any further questions. Fantastic. So we're sort of working to time. Jonathan, can I just take the opportunity to thank you once again? I mean, it's a really expert insight. It's a real privilege to hear an expert such as yourself. And I'm sure people on the call and people on this webinar have really benefited. So, Jonathan, thank you very much. Thank you for your time. Thank you for your expertise. And as importantly, thank you for being so supportive of CHAI, an organization that is that's growing and developing and reflecting what is going out there in the world and supporting people, Jewish people. Can I particularly thank Louise Hager, our chairman, and Lisa Steele, our chief executive officer, for offering so much time and support of this organization. Thank you. Without you, we wouldn't be having experts like Jonathan joining us. So thank you all. Thank you all for joining us for the meeting. And next year, we'll have another lecture. So I hope that will all be in person. So thanks once again. Thank you.